Hello, this is the concept application project for healthcare delivery systems. I am Melinda Sims, and I'll be talking about the patient care delivery model today. An overview of patient care delivery systems. In general, a complex adaptive system, according to our text by Crowell, is a complex, nonlinear, interactive system that adapts to changing environments. The thing with these complex adaptive systems is that they are composed of many independent agents that interact at all levels through relationships. These relationships spark the emergence of new ideas, structures, and patterns. They can be somewhat unpredictable, but have proven to be very effective, especially in the realm of patient care. The patient care delivery model specifically, according to the Massachusetts General Hospital, is a state-of-the-art infrastructure for the delivery of patient care. They incorporate interdisciplinary, patient and family-centered dynamics, an internal health environment which is influenced by the socio-political and professional dimensions of nursing practice. And basically, the authority of this patient care model lies in the hands of the nurses and interdisciplinary staff. The key concepts include continuity of care, systems improvements, nurse staffing, and a culture of learning to really get effective patient care outcomes out of this system. The leadership in this patient care delivery model influences care greatly. This healthcare model relies heavily on the participation of the nurse and the concept of patient-centered care. Leadership factors in this model include nurse participation. Without the nurse and their willingness to participate, this model is unsuccessful. Nurse autonomy is also essential. Nurses have to be able to control their own patient to really have the patient benefit from care outcomes. Staffing ratios and nurse overtime are huge in this care model. And nurse satisfaction is a key component. If your nurses are satisfied and your staffing ratios are adequate, nurses aren't overworked, they feel like they have more time to put into their patient. This in turn is going to lead to better patient care outcomes. It is also said in the article Evaluation of a Patient Care Delivery Model, Patient Outcomes in Acute Cardiac Care, that the patient care delivery model highlights that patient, nurse, work environments, and system factors interact interdependently and dynamically to influence outputs. The organizational culture and support of this microsystem is based on a framework of culture of learning. Patient-centered care and education is a primary focus, as well as really focusing in on best practices, evidence-based research, transparency, and really looking at mistakes or near misses as an opportunity for learning rather than criticism or, basically not taking that into consideration as far as how we can improve our healthcare system. Staff empowerment, open communication between staff, between patients and staff, and in my unit's case, between providers and nurses is going to be essential. Teamwork, coordination of care, and mutual respect between all parties is also crucial. The patient focus of this care model is really patient-centered care. Patient-centered healthcare is going to focus on achieving the best patient care outcomes through the incorporation of patient and family-centered care and a culture of learning. As far as the staff focus goes, the staff plays a vital role in this healthcare system by drawing on patient, caregiver, and system related knowledge to aid in the best possible outcome for the patient. Staff need to establish and maintain patient and family relationships. They need to integrate patient related knowledge in their care. Really take into consideration what your patient has to say. They do know themselves the best. This also makes them feel like they're part of their care and that they're not just having things done to them, but rather they are having some sort of a say in what's happening. We need to utilize caregiver related knowledge to impact our care delivery. Really rely on the people who know these patients. In realms of the NICU, we primary patients and continue to care for them throughout their stay. When you are taking care of a patient that you're not the primary nurse for, it's really beneficial to rely on people who do know that patient, whether if it's in shift to shift report or if that nurse is taking on a different role for the day. Really utilize their caregiver related knowledge to obtain the best patient care outcome. And the role of your staff is also going to be to navigate the system for use of system related knowledge and more effective patient care transitions. We'll talk a little more about technology in this care model in a few slides. According to the Jefferson Interprofessional Clinical Rounding Project, it was stated that emerging research has suggested that improved collaboration among healthcare providers can improve the delivery of services and make a positive impact on care. Clinical rounding is going to be a key component in the interdependence of care team. If we are able to share our caregiver related knowledge through interdisciplinary rounding with different clinicians who have knowledge that's specific to this patient, we can definitely impact our patients positively. Strategies to establish interdependence of the care team would be multidisciplinary rounding or bedside reports, caregiver related knowledge, really relying on those people to give you information that you may not be able to gain anywhere else. And clinical education, definitely continuing education and staying up to date with best practices and evidence-based research is going to aid in the improvement of patient outcomes. The use of information in healthcare technology is vital to patient care in any delivery model at this stage. Specifically, this patient care delivery model can benefit from information technology because we are able to get a more adequate view of what's going on with this patient. We're able to see past care experiences as well as the current care that is occurring for this patient. Transitions are more smooth from one unit to the other. We're able to see lab results and diagnostic tests, with really the click of a button. And we as nurses are able to input our assessments and data that we see on this patient, and the physicians or other providers, clinical staff are able to access that information quickly. Forms of information technology in the clinical setting include computerized charting systems, physician computerized order entry, and readily available lab results and other diagnostic tests, like I previously mentioned. And medication administration and documentation can be done safely using the 5 rights. We can also use this as a tool to be able to document our intake and our output accurately. There are different systems that can calculate these totals for us, and that's just another measure to make sure that we are accurate in what we're doing for our patients. Process improvements allow for adjustments to be made within the microsystem based on evidence-based research and best practice. Information is ever-changing in healthcare, and we must adapt to this change to be able to provide safe and effective patient care. If we look at the nurse's role in process improvement, it's really geared towards research. Once we've researched a topic, we've understood that a change needs to be made, and there is a place for improvement in our process. We're going to obtain all the required data that we need. We're going to review the process that we have in place and revise it accordingly, and then implement this new process into our care practices based on evidence-based research, and possibly tweak our policies and procedures a little with that as well. Staff performance patterns in this microsystem are really going to be focused on patient outcomes. We're going to look at avoidable costs, streamlining delivery, and using data feedback to promote basically a positive outcome for our patient. Best practice for evaluating staff performance patterns are going to be the use of benchmarking information on processes and outcomes. We can use data walls for our staff to see a visual on what our performance in our microsystem looks like. And then the extensive use of protocols and guidelines for core processes, and then encouragement of innovative thinking and tests for change. Based on the patient care delivery model, in reference to my NICU clinical setting I work in, culture is a huge aspect that can be targeted for improvement. The current culture is predominantly provider managed with very little nurse autonomy. And for this patient care delivery model to be successful, nurses have to have autonomy. They also have to have a culture of learning, and that is lacking in my NICU at times. Nurses are sometimes made to feel inadequate, questions aren't warmly welcomed, and mistakes are not accepted. Transparency is definitely not there. So we need to try to incorporate these into our practice and into our culture, and really see them as learning opportunities or opportunities for process improvement. That kind of leads into the next thing. The delivery of this improvement is going to be achieved through MSimSRN collaboration meetings. The NICU leadership and providers can meet together to discuss ways to initiate a change in culture. We're going to really focus on that learning aspect, patient-centered care as the primary focus. If we encourage transparency in the realm of incident reporting and really, coming to terms with the fact that we make mistakes, we can identify where the gaps are and really, verify the educational needs and the areas we need to improve on for our patients. We can also verify staff competencies through skills checkoffs and really gear our educational goals towards those competency needs. We can also encourage interdisciplinary collaboration through bedside rounding and care meetings, and encourage nursing staff to seek out learning opportunities on their own. Really continue this ongoing evaluation and just adjust accordingly. Thank Thank you.